that way. It probably doesn't even make sense to anybody because it doesn't make sense to me. But hey, if it helps at least some of you remember it, then I've done my job, right? If we want to build bone, what kind of, I am a cell that builds bone. So what's my name?
Osteo.
Yep, say it. I know you're there. Exactly. Say it out loud, Omar.
Osteoclast?
Osteoblast.
Oh, blast. Okay.
Right. So, what can we say? Do you want to just take my key and log me out? I'll be right back.
Let me just pause this.
There's blast and
Blast.
blasts. Build. Blasts. Did you punch now? No. Even though it's a C, not a K, you should punch this. Even though it's a C, I know that. Blast, build, blast, kill. So osteoclastic activity does what to bone?
Breaks them down.
Wipes it out. Osteoblastic activity builds it up. Exactly. So blast, build, blast, kill. Is that helpful?
Mm-hmm. Oh, it's the ear.
Is that an ear?
Mm-hmm.
That's so gross. So bone reabsorbing cells would be known as an osteoclast because it kills it, reabsorbs it, kills it, right? All right.
Oh, this one's messy.
Know the what is the structural unit of bone? What is that unit of bone that makes it work? Does anybody know? So when we're talking about bones, osteo is bone, right? All right. So who wants to look in their book and tell me, we'll be right on the structure, what the main, yep, structural unit of compact bone is called a what?
Spongy bone.
That's a type of bone. Okay, spongy bone is a type of bone. Huh? Osteons, exactly. And osteon is the
Bone cell.
structural and compact structural unit of bone, right? Now, when we look at, has anybody ever used a loofah in the shower?
Yeah, it's a little like spongy.
So if you use a loofah, you see that there's all of like these, they call it sponge-like, right? All of these projections of lines of bones going all over the place inside the bone. So you can see that in your book. Sorry, I just had too much, I apologize. If you go to page 178, so Omari, the spongy bone, why is that spongy bone? Why don't we just have a hard bone all the way through? It'd help us a lot with fractures, right?
Because it would be too heavy.
It'd be too heavy, right? If every piece of your bone was solid bone, you would be able to walk. You'd be like this, right? Trying to move your leg because of the way it's done. So we need that spongy bone on the inside because the hard outside, spongy inside, it's lightweight, right? What is that, those projections called? If you look on page 178, those projections, needle-like threads of spongy bone, what are those called? Trabeculae. Yep, trabeculae. So that's a good thing to remember as well, okay? How many pairs of true ribs do we have? True ribs?
10? Oh, 12. Then we have
True
two.
ribs are 12.
How many false ribs? 2 pairs.
I think there's 2, but I'm not 100% sure on that, actually. I'm not 100% sure. Okay. Now, we have to know curvatures of the spinal column, right? Anybody ever see Hunchback of Notre Dame? Okay, Hunchback of Notre Dame had that big thing up on his back. What's that actually called?
Kyphosis.
Kyphosis. Kyphosis, right? So when you're at work, you're going to hear them say the patient is kyphotic, meaning they're usually like this, right? And what does that really impair somebody's ability to do? Breathe, eat, swallow, see where they're going, correct? On the other spectrum, we have lordosis. What's that? On the bottom. They call that a sway back. Okay, and then scoliosis, that's the S, right? I don't know if they do it anymore, but back in the day, we used to get, in class, we'd all be at our desk, and the nurse would come in, and believe me, HIPAA didn't exist back then, they did not care. You go in there, you bend over, they line you all up, and she'd look through your hair, and she'd measure your back, and if somebody got sent to the nurse's office, they either had lice or they had scoliosis. It was either one, right? Because, well, we wouldn't agree with them nowadays, but, hi Siobhan, did you punch it for me? Thank you. What connects cartilage, what joint uses cartilage to connect bones? Okay, so we have a bunch of different joints, right? Diarthrosis, synarthrosis, and amphiarthrosis, okay? Synarthrosis is an easy one, because SYN anything means none, right? So our synarthrotic joint, does it move or not? It does not, right. So, can I? Okay, so on page 196, you have different kinds of joints, right? So a synarthrotic would be no movement. Amphiarthrosis is a partial movement. In diarthrosis, you have free movement, right? So, joint, and there's really not too many, would be an amphiarthrotic joint.
One that's not moving.
So when a woman is in labor and giving birth, there is the squishy part in between the pelvis, right? And that is meant to open up to allow the baby to pass. That's amphiarthrosis. It's slight movement, right? But would we really want a joint in our hip to be free movement all in the center of our pelvis? Why? We wouldn't be able to walk, right? We'd be all over the place. So that's an example of an amphiarthrosis. Synarthrosis, what's that? No movement. Give me an example of that kind of joint. In your skull, yeah. Matthew came in, yes. Siobhan came in. Excellent, Diane is here. Great, everybody's here, wonderful. All right, so what kind of joint uses cartilage to connect to a bone? So, go ahead. Somebody confidently tell me that answer. Is it diarthrosis?
I don't know.
So we can look that up, right? In our book. Diarthrosis means freely movable, but what else? This joint uses cartilage to connect to a bone. Synovial is the synovium is within the joint. It's that fluid. So it's part of the joint, but it's not the name of a joint. So joints would be diarthrotic, synarthrotic, and then we get down to hinge, ball and socket, stuff like that. So the synovium is when you have somebody who, like, they call it tennis elbow. They get the big massive thing on their elbow, that's all infected fluid. So that fluid within that joint gets infected. So I have my book with me, so I don't know why I'm looking at yours all the time. But
It's diarthrosis.
is it a diarthrotic joint? Excellent, perfect, a diarthrotic joint. Be confident. So if you give me an answer and I don't think you're confident in your answer, I'm going to question it some more. Because the last thing you want to do is walk into your room And when it's a patient's family member, or someone asks you a question like it, you can say, you know what, I'm not sure, I'll get back to you, but you never fudge an answer, right? You'd be like, I can get back to you, or you just confidently answer it, so. If I had a Bouchard's node, what would that indicate I have? As a matter of fact, I do have one. It's right here on my finger, right here. A Bouchard node. Huh?
Rheumatoid arthritis.
What's that?
Rheumatoid arthritis.
You're close.
No osteo.
Bouchard's is osteoarthritis, yep. Osteoarthritis is an inflammatory process. Rheumatoid arthritis is autoimmune, and it's an inflammatory arthritis. Osteoarthritis, how do we get that? Wear and tear, lots of use, right? So, let me make sure I got that right. So that I didn't give you the wrong answer. I would know on page 200 and 201, osteoporosis, rickets, osteomalacia. On page 202, Paget's disease.
We got Bouchard codes on 205.
Notes on Bouchard in 205.
So osteo is non-inflammatory, rheumatoid is inflammatory, okay? Gout is inflammation. What's an intercalated disc? And where is it found?
Vertebrae?
Cardiac, yep. So that is super important because we can't have things just kind of moseying along when it comes to our heart rate, right? What's wrong?
I didn't hear you.
An intercalated disc.
Okay.
Where is that found? And that would be found in cardiac muscle because that's like grease lightning, that like really whips that electronic impulse through the heart, okay? No, understand a sprain versus a strain, which to this day I will screw up. Like 30 years into this career, I will still screw up a sprain and a strain. So one, you know, I'm not even gonna confuse it here, but know the difference, strain versus sprain, okay? Sprain versus strain. Know your types of muscle tissue, cardiac, smooth, striated, voluntary, involuntary. Okay, so during your section that you've been doing, chapters 8 and 9 in AFP, you also have, so your exam is next week, correct? Are you all clear on what is due next week? You are. Have you been handing in your pre?
Yes.
Yeah.
Yeah.
Okay, are the grades going in?
The only grade we got was closed.
Yeah.
Who's with it?
You should. Your pre-test should have gone in. I'll check into it. So, what I would recommend doing is looking into your ATI books. So, tell me one thing that you had on ATI, on your templates.
Nuclear scan?
Nuclear scan, osteoporosis. So, if we were to look up osteoporosis, musculars in the back. So osteoporosis, I don't know if any of you have these books on you, but this is your ATI, right? So, things that would be important and things that that template asked you. Did the template ask you about risk factors
I believe so, yes.
for osteoporosis? So, I want you to tell me risk factors for osteoporosis. Shut on up. See what you can do without looking at your book first. See how much you recall.
Falls.
A fall?
Falls.
Falls are a result sometimes of osteoporosis, but we could say frequent falls, right, might clue us into something. But a falling is not going to cause osteoporosis.
Steroid.
Vitamin deficiency?
No vitamin deficiency. Yep. What
Steroid.
vitamin in particular?
Vitamin D.
Vitamin D.
Steroid
So
therapy?
loss in bone density is the result of osteoporosis. So when we say risk factors, what we're saying is age. What particular about age?
Over 60.
Older than 60, right? So what if I have a patient come in and they're over the age of 60, their vitamin D level is low, they're falling. Now, is the fall going to cause the osteoporosis? No. What is the danger with falls and osteoporosis?
Fracture.
Fractures, exactly. The fracture is what's key there. So, give me a few more.
Nutrition, lean body,
Nutrition. What about nutrition?
insufficient intake of calcium.
So, calcium and vitamin D, right? Because what does calcium do? Or what does vitamin D do?
It increases.
Calcium. If we don't have, so if you ever look at a gallon of milk or any milk, it says fortified with vitamin D. You know why that is? Because if there's no vitamin D, the calcium's not going anywhere into your bones. Okay? So it's calcium and vitamin D deficiencies. Okay? What else about diet? Deficiency in what?
Calcium.
Right, calcium. So we could have decreased or increased protein can also be a cause. What about bad habits? Smoking. Smoking, and smoking. Alcohol use. ETOH is alcohol. What makes alcohol use even worse when you have osteoporosis?
The liver is not able to
You could fall.
You fall. Yeah, you stumble, right? You see people stumbling around all the time when they're drunk.
What about lack of exercise?
So, lack of physical activity, decreased physical activity is going to be risk factor for osteoporosis, absolutely. So if you look at your chapter on osteoporosis and ATI, they're going to have a whole ton of risk factors, okay? So, know those risk factors, and it's important because sometimes, and it's really critical, just a test taking tip, that you read that question. Because I might say something on a test like a diet high in vitamin D. If you don't read that correctly, you might see vitamin D, oh, that's the answer, and check it. But is it high vitamin D? What are we worried about vitamin D?
Low.
Low, exactly. So make sure you pay attention to that question, all right? Tell me what a patient looks like or expected findings of osteoporosis.
Kyphosis.
Hmm?
Kyphosis.
So, yes, kyphosis. Kyphosis, yes. Yes, kyphosis, I'm sorry. So kyphosis, which the other name for this is, what's the other name for kyphosis? It's not nice. Hunchback. Yeah, it's not nice, but What else? Tell me about osteoporosis. Bouchard's notes, those are more indicative of what type of disorder? Osteoarthritis, correct. You could have Bouchard's nodes and have osteoporosis, but you would most likely have osteoarthritis and osteoporosis to get the Bouchard's nodes. What else? Someone said it earlier. Falls. So an expected finding is frequent falls, right? Another finding, fractures or easily fractures, right? If I am walking along and I trip and fall, I should not fracture my femur, correct? If I'm just walking through the classroom and I trip and fall, or you fall out of bed, should you be busting your femur?
Shouldn't be.
No, but why shouldn't we be busting our femur?
Because our adipose tissue.
Well,
or-
some more than others, yes. But I would never break a femur in my life if that was the case. The thing of it is that's a really, really strong bone that requires a huge amount of force to break, right? So if I see somebody that says, oh, I just tripped and fell, and their femur's busted, now I'm worried. Osteo, or God forbid something worse, like a bone cancer, right, is going to fracture a femur if you just trip and fall. It shouldn't happen.
Happened to Frank
Right?
Gallagher.
Toes, completely different story. Busted their toes like a million more times, all the time. Okay?
I'm trying to figure out
So
why he
what
broke
are
his
the
femur.
other findings of osteoporosis? Decreased bone mass, decreased bone density, all right? You've all seen me get up from a chair, right? Right? So osteoporosis, patients are in pain. They're in pain, right? They might not be able to lay on one hip, or they can lift to the other hip, or their shoulder hurts them, they're laying on their shoulder. So we had other things that, we had ORIF, right? ORIF is what? Open reduction internal fixation. So we used to see back in the day that people would have these like big things around their legs, like a halo, right? And there would be pins in them and stuff. We don't really do that anymore unless they're really, really fractured bad. But normally we put plates, right? So if somebody falls and hurts themselves and has a fracture, we put in plates, okay? So for an ORIF, what has to be present in order to have an ORIF? A fracture, right. Start yelling them out to me. Types of fractures. Comminuted. You would pick that, you're right. Open, that's much easier. What else?
Closed.
Closed.
Green stick? What was that? The green stick?
I can't hear you. Oblique. Oblique. I heard another one out there. I heard green stick. Huh?
She said complex.
Okay.
Oh, compact.
Compact. Compound.
Yeah, I said compound.
Compact.
I did not hear compound.
So, who would we most likely see a green stick fracture on?
A young kid?
Because their bones are rubbery, right? Because in the beginning of the chapter, you guys talked about ossification, right? So that ossification means that hard bone is taking over that softer bone or the cartilage, right? So if anybody's ever been out and pulled the stick off of somewhere and snapped it, the green stick, you'll see that green, and it doesn't break all the way, right? Whereas you feel like all old and crusty, like my legs, and you snap them, it's gonna snap right through, right? Because they're old bones. Whereas the younger ones still have that level of like rubberiness to it. So a green stick is an incomplete fracture, right? Very typical in children, very, very typical in children. So comminuted, oblique, spiral. What kind of injury would you have to have a spiral fracture? A twisting. You know who gets spiral fractures? Not to be gross. You guys know I worked in the ER for a long time. People who like use a meat grinder. Or they'll try to put something in and it catches them, it spins them, and it just spins it. It's awful. There are times people have come in actually with their arm in the mechanism itself, and like we've had to get maintenance to come up and like try to disassemble this piece of equipment, which usually the maintenance guys pass out as soon as they see like all this neck, like muscle and stuff ripped off. So it just really never works out well. But so understand your types of fractures in terms of open, closed, etc. All right? Is this helpful for you guys? I want you guys to tell me, so I am a patient who just had an arthroscopy. Did I tell you the story about my mother? About wanting an arthroscopy? Did I tell you this story? So, not to give too much away, but my mom has a fistula, and generally the fistulas are in bowels, right? Which is unfortunate, but she's stubborn. Stubborn. So she's like, Margaret, I just don't get it. Like, why can't they do an arthroscopy and call it a day? I'm like, because it's in your blood, not in a joint. So the last thing you want somebody to do is an arthroscopy, because what does an arthroscopy look at? Looks at your joint, right? So an arthroscopy looks at a joint. If you have a fistula in your bowel, do you think an arthroscopy is going to be right? No, it sure doesn't. I'm like, if they do an arthroscopy for this, I would switch doctors, because they clearly don't know what they're doing. So, arthroscopies, and that's, again, a chapter in here. So, what do you remember about arthroscopy? Have you done your ATI things yet? I'm guessing that's a no. Am I right? Yes. So what does an arthroscopy do? It allows for visualization of the internal structures of the joint. Has anybody seen one? Ever seen one? Has anybody ever seen orthosurgery? We talked about this, right? It's horrifying. Rough, brutal, saws, screws, you name it. Bad. Huh?
I see the surgery.
Oh. No, thank you.
And her shoulder, because it can happen on.
So, an arthroscopy, what is it? I'm a little too long. Oh, okay. An arthroscopy allows for visualization of a joint. So I just underwent an arthroscopy, all right? The arthroscopy entails a fiber optic scope, okay? So you're gonna have to cut little places in to actually get those cameras in, right? It's not like when we do an arthroscopy, it's not an x-ray. It's a fiber optic scope that actually goes into the joint, okay? So you know there's going to be what involved? Cutting, an incision, right? So if we make an incision, what are we breaking? Skin. The skin. Number one, infection. Signs and symptoms of infection? Swelling, redness, pain, heat, and loss of function. One more. Drainage. What kind of drainage? Purulent. Exactly. Purulent drainage. Okay, so what's something we might want to teach the patient? Report signs and symptoms of infection. If they don't know, yes, keep it clean, but if they don't know what the signs and symptoms of infection are, you cannot, so now that you've been in school, there are things that are going to be very, very obvious to you, and you're going to be like, ugh, how do they not know this? Like, this is basic knowledge. It's not. Believe me when I tell you. Basic knowledge does not exist, okay? Patients sometimes do not understand, oftentimes do not understand. So can you have swelling and not be infected? Absolutely. The infection, so they may have swelling, so you have two extremes. They'll have swelling, and the patient will call and be like, my knee's swelling. Well, it's supposed to. You just like literally tore it to pieces, right? It's going to swell. But what we want to tell them is look for redness, feel for warmth, look for drainage, right? All of that stuff. So that's one thing we want to teach them. What else can we teach them about comfort measures?
Elevate.
Stay on top of the pain.
Stay on top of the pain meds, right, but do you think we'll be throwing opiates at these people? No, we really don't want to be throwing opiates. What's the issue with opiates? What's the
It's
Hmm?
addictive.
Okay, addiction is one. Worse than addiction, well,
It suppresses the respiratory system.
it suppresses your respiratory system. It suppresses your respiratory system. What's there a good likelihood you may get?
Die.
Pneumonias, atelectasis, yes, and of course dying, which is never a good outcome.
Escalating.
What else? Who?
Constipated.
Constipation, and I mean one dose of Percocets. Those patients can't poop and they end up getting perforated bowels or something. I mean, it's like that, really. And I'm not talking about an older person, I'm talking about, you have a 40-year-old guy go in, have rotator cuff surgery, come out, take a Percocet and boom, no poop, right? Bad. So, what else? What do we usually do? If we like twist our ankle or something, what's something we might do? Ice. So that's rice. Rest, ice, compression, elevation. So the compression thing, that would depend on the doctor. So do we have a splint? Do we have a sling? Right? We would instruct the patient on that use, right? Do we just let them walk around as much as they want? Who determines the weight-bearing capacity of the patient? The doctor, right? So it may not be the same for every patient. That's what we have to make sure. Is this patient going to need crutches? Are they partial weight bearing? Do they have a walking cast? Are they full weight bearing? So that is something you absolutely need to teach the patient because it can go both ways. I went in and I had my knee checked, okay? So I got an immobilizer. And I see this big immobilizer on, and I can't even walk like a soldier with an immobilizer on, right? So I made very, and understandably so, make the assumption that I can't put any weight on my leg. I can only walk like a soldier. Like, who's supposed to walk with this crap on, right? What is the problem when we're not walking around? Blood clots, right? Especially after extremity surgery. So we want to make sure that we verbalize to the patient, listen, I don't want you running a marathon. It all depends on what the doctor says. I'm not going to tell them to run a marathon, but I want you to get up. You can either walk for short distances using a walker, using crutches. You do not want to do full weight bearing. You have no weight bearing for a week. You have no weight bearing till you see a doctor. You can partially weight bear using crutches. You have to be very clear about those instructions. Because if you don't say anything, they may not move at all, and they should be. What if that's a shoulder? What if after shoulder surgery, they don't move their shoulder? What do you get? Frozen shoulder. That's like glue. You can't move it. Or they say, oh, I'm gonna do whatever I want, right? And I'm gonna run a marathon. And then they come in, and it's infected, and it's messed up. And why? Because it was non-weight bearing, right? So that would be something I would teach a patient. What else? Do we use ice or heat? Ice for the first 24. What do we teach about putting ice on the skin? Put something in between it, yeah. What is the most common form of ice that we use? Frozen peas. Right. I'm not kidding you. When my kids were growing up, I literally had like the injury bag of vegetables where it wasn't eaten, it just was in there for putting on my kids. Nobody got hurt. I'm serious.
We
Um,
don't use that.
Huh?
We don't use that now.
I still do.
Well, I'm not saying you're
easier.
gonna whip it out at your job. No, but I'm saying, when somebody goes home, if they tell you, I don't have an ice pack, my refrigerator doesn't make ice, what can you tell them? Use a bag of frozen vegetables if you have to, right? No, what, if somebody whipped out like a bag of frozen peas at work, I'd be like, really? Right, we would use what we have in the facility, but remember, you're educating a patient to go home, okay? People aren't gonna go out and buy these expensive, like, ice packs or something like that, just to go home for 24 hours. We wanna tell them to watch it. Watch for redness. Make sure it's not getting too warm. Okay, so those are things we would teach somebody about arthroscopy. All right? Arthroscopy, osteoporosis. All right, muscular disorders. Somebody has a muscular disorder versus a bone disorder. Tell me what your prefix is going to be for each.
And what?
If you have a muscle versus a bone disorder, how are those words going to vary? So muscle would be myo, right? Or mya. What about bone? Osteo. I know you guys just took a test on medical terminology, right? So, good, now.
No, we don't.
No, we
I'm like, test.
Oh, my bad, that was a mod one, I'm sorry, I'm confused, clearly confused. So, I may not know, because we all know in medicine, we do big, long words, and it's like they have a da-da-da-da-da, what does that mean? Oh, they have a short word. Like, it doesn't really, sometimes things sound really horrible, and it's like, no, this is okay, whatever. So, if we know our prefixes and our suffixes and roots, we could probably figure these out. So if I see osteo in front of anything, what's it gonna be? Bone. If I see myo in front of something or within something, what will it most likely be? Muscle. So give me some, I'm gonna holler some stuff out to you. Osteomyelitis. Myositis. Myasthenia gravis. Osteogenesis imperfecta. Did anybody ever see that movie, by the way? What movie was that? Oh, come on.
It's at the tip of my
Ah.
tongue. I
The
know.
guy, he had osteogenesis imperfecta, and he went out to like create cartoons. He was in a wheelchair. Was it Bruce Willis with him? I can't remember. Broken.
Yeah,
Broken?
broken.
Excellent movie. Excellent. You guys have no clue what I'm talking about. Who was in it? It's a really good movie, though.
Veronica, like, you got me. I don't know.
It's a really good movie. And, let's see, what else can I think of? Osteoarthritis. Okay.